Hi, my name is Lolita Prasad-Reddy. I'm one of the clinical pharmacists over at Rush University Internists, and I'm excited to be talking with Dr. Broderick today and talking about insulin and the treatments for type 1 diabetes. So the objectives of this lecture would be to describe the pharmacology, adverse effects, and monitoring of different insulin formulations, evaluate the different insulin formulations and determine appropriate uses of each, list the indications for when insulin treatment would be necessary, develop appropriate initial treatment regimens and monitoring plans for patients with type 1 diabetes, and apply patient data to develop appropriate monitoring, appropriate follow-up treatment regimens and monitoring plans. In patients with type 1 diabetes, they all require insulin at the get-go at diagnosis because the pancreatic beta cell destruction leads to a complete and absolute deficiency of insulin in those patients. As such, they're required insulin replacement for both their basal needs that prevent daily fluctuations throughout their day, as well as their bolus needs, which would provide their postprandial glucose coverage. So when we think about what insulin is it's a peptide hormone that is secreted from the beta cells of the pancreas, found in the islets of Langerhans, and it is the major regulator in glucose secretion, with the other form of major regulator in glucose secretion, that hormone being glucagon, which would have the opposite action of insulin. In terms of the efficacy of insulin, there's no maximum A1C reduction that you would obtain with insulin in terms of either type 1 or type 2 diabetes, because you can push up the dose as far as you want. There's no maximum dose. You're only limited by side effects, specifically hypoglycemia. But in the majority of patients, you could assume a pretty safe A1C reduction of 2% without predisposing that individual to frequent hypoglycemia. In terms of the pharmacology of insulin, when blood sugar raises, that's going to promote insulin release from the pancreas. That insulin is then going to first enhance glucose uptake by both the skeletal and peripheral muscle tissue. And then at higher doses of insulin, it's going to convert it's going to stimulate the formation of glycogen from glucose in the blood. But again, that's not going to be your primary mechanism. That's typically going to occur when you're giving exogenous insulin at much, much higher doses. When we classify the available insulin preparations, the most frequently way they're used to classify is based on both their onset of action as well as the duration of action. All commercially available insulin preparations contain only the active insulin peptide, which is cleaved from the larger proinsulin peptide in the beta cell. Characteristics that are commonly used to categorize insulin preparations would include the source, the strength, the onset, and the duration of action. However, nowadays we use primarily both the onset of action and duration of action. Insulin is also available in several different concentrations. However, the most common concentration that you would see would be the 100 units per ml, which basically means that there's 100 units per ml. Most insulin is then dispensed in 10 ml vials, which will provide the patient 1,000 units for that month. When we think about historically what was happening at the beginning of the 1900s when insulin was first discovered, frequent injections were given in the form of regular insulin, which is a fairly short-acting insulin, and so that at the time was the only insulin available, and that was given to control the symptoms of hyperglycemia. So subsequent insulin formulations really focused on products that would provide patients a delayed onset of action and a longer duration of action that would provide them their basal coverage to prevent those daily fluctuations in blood glucose a day. So the analog long-acting insulins that we have available would be your basal coverage, comes in the form of glargine and detamir. And you can also use intermediate NPH, which we'll talk about in a little bit later, as your basal coverage as well. The analog rapid-acting and short-acting insulin, such as Lispro, Aspart, Glulisine, and regular insulin, have rapid onsets of actions, anywhere from 5 to 30 minutes, and so they're really used for their bolus coverage because their duration of action isn't that long either. To really understand why we try to give insulin in the formulation we do, it's important to understand the underlying physiologic secretion of insulin. So basal insulin, which is going to be that insulin that's given to prevent those daily fluctuations in blood glucose, is released by the pancreas in a pulsating fashion every 12 minutes. So it occurs at a rate of about 1 unit per hour. So when you assume that there's 24 hours in the day, your basal coverage in a normal, healthy adult would be about 24-25 units of insulin per day. Bolus insulin, which is going to provide your prandial or your post-meal coverage, is released when your blood sugar gets greater than 100 about 10 minutes after the ingestion of food. And it's estimated that depending on the food intake, the patient, a healthy normal individual, probably takes in about 5 to possibly 10 units of insulin per meal. So then the normal pancreas secretes about 25 to 50 units of insulin per day. So if you think about the normal patterns of insulin secretion, here you can see that those blue peaks are going to be your breakfast, lunch, and dinner meals. And your basal insulin is going to be released from the pancreas every 12 minutes to prevent those daily fluctuations in blood glucose as it would come with the morning rise in blood sugar, daily fluctuations, exercise, so anything that has to do outside with the patient eating. Once a patient starts to eat, that insulin bolus is going to be secreted from the pancreas within the first 10 minutes after eating. So you could see once there's a meal, that insulin's going to be secreted, and then slowly your blood sugar will come down after the next 2 hours. After that, your next meal, your insulin is going to be secreted after 10 minutes of eating, or when the blood sugar supersedes 100 milligrams per deciliter. And then after that time, the blood sugar will continue to come down. And then again, at dinner time, once you start eating, that insulin will be secreted from the pancreas and then work to bring down your blood sugars. So this would be why we use what's known as basal bolus coverage, which is going to be the most physiologic type of way that we could provide supplemental insulin to mimic normal physiological processes by giving a long-acting insulin once or twice daily to provide those basal needs, and then providing those mealtime coverages at breakfast, lunch, and dinner. And again, because patients with type 1 diabetes do not have any endogenous insulin production, it's really imperative that we provide them the appropriate amount of insulin to maintain their glucose needs. So your physiological insulin replacement is going to be made up of 3 different things. One, your basal insulin, which is going to become in the form of either a long-acting insulin once daily or an intermediate-acting insulin twice daily. That's going to mimic that constant release of endogenous insulin that regulates lipolysis and hepatic glucose production. Typically, when we give patients basal insulin, long-acting insulin in the form of glargine or denomir, there's not a really high risk of hypoglycemia because there's no peaks that's seen with those agents. Again, those agents are just given and they're absorbed from the subcutaneous tissue very, very slowly. So for that reason, they really don't predispose patients to high risks of hypoglycemia. For prandial insulin, that's your bolus insulin, and that's going to be given in the form of either a rapid-acting or a short-acting insulin, and that's given to mimic the response of endogenous insulin to food intake. So again, those insulins are going to have a very quick onset of action, within 5 to 30 minutes based on the formulation, and the duration of action is only going to be anywhere from 2 to 5 hours. So pretty quickly it's going to be renally cleared and removed from the circulation. However, because these insulins work so potently, so quickly, they really are the agents that can predispose patients to high incidence of hypoglycemia. And then a correction dose insulin is basically given to correct pre-meal or between-meal hyperglycemia, with the thought that being, if a patient sits down to eat a meal and they are instructed to take 5 units of a rapid-acting insulin with that meal, that 5 units of that rapid-acting insulin is really given to cover the meal that's going to be eaten to prevent rises in blood sugar. However, a correction dose takes into account that the patient, when they sit down to eat their meal, they may not be at their blood glucose goal. So for instance, if you had someone that was already at a blood sugar of 250 when they were sitting down to eat their lunchtime meal, that insulin unit prescription of 5 units will only prevent further increases from that 250 for that meal. So a correction dose is the philosophy that you want to correct it to a baseline with additional insulin prior to the meal time. So this is just a diagram that shows the kind of different insulin types and basically their onset of action versus their duration of action. So you can see that where they peak is really going to be very important, and those agents that peak sooner are going to be those ones that predispose patients to hypoglycemia. You could see that NPH has a duration of action of about 12 hours, but there is a slight peak with NPH. So although it does provide your basal coverage, there is an increased risk of hypoglycemia with NPH. But you could see that glargine, which is your Lantus formulation, has a duration of action of about 24 hours, and really we do consider it peakless. So those are going to be the ones that do not increase your risk of hypoglycemia. What's really important to notice is from the pancreas in a healthy non-diabetic individual, they're going to obviously have the most potent insulin secretion. So regardless of what type of supplemental exogenous insulin preparations we provide the patients, it's still not ever going to be as potent or as effective as that endogenous insulin that is secreted from the pancreas. So that concludes section 1. In the next lecture, we'll start talking about the individual insulins.